So this is a patient that I saw in my clinic who came in to me, a 55-year-old woman with bilateral hand numbness. So maybe starting with Burke, maybe you can talk about, what else do you want to know about this patient's history?
Has she ever had a problem with her cervical spine, like a strain, sprain, any previous injuries? And does she have any neurological additional symptoms in her history, maybe?
Mm-hmm. Yep, those are all great things. So, one thing I learned when I was on the wards is as soon as I meet a patient, I always just kind of ask a very open-ended question. So basically, I say, what's bringing you here? And then, tell me the story of how this came to be. I found that to be a really good strategy for sort of, patients to automatically tell you sort of the, pertinent positives, pertinent negatives, rather than, sort of getting pigeonholed with, very, very specific questions. So I encourage you guys to maybe try that and see if it's beneficial for your interactions with patients. Now, sometimes patients go on completely, wild tangents that have nothing to do with what they're there to see you for, and in those cases, it's very important to, get them focused. But I think you're right on point, Burke. So really important to ask those questions. So I have them tell me their story, right? And so her story was that her symptoms had been present for 1 year. So obviously very important to understand the duration. Someone who's had symptoms for 1 week, is probably going to be, less, urgent than someone who's had patient for, years. Okay. Her symptoms affected all fingers all the time in her own words, and she described them as electrical shocks. I always have them have patients, tell me, how would you describe, your pains in your own words? Sometimes, it's an expletive, which you probably can't put in your, your formal medical documentation. But hers were, electrical shocks, in her arms, worse with coughing. Divine, do you know what that's called when someone kind of has symptoms worse with, coughing or turning their head or?
No idea.
That's okay. Yeah, it's a kind of a read my mind question. So the two sort of things to look for or maybe ask is, if patients sort of get these zaps down their extremities with, bending their neck or extending their neck, that's called a Lehermitz sign. And if they kind of get these symptoms with sort of turning their head and, extending their head, that's called a Sperling maneuver. Those are actually some things that you can test in clinic to see if the patients say, oh yeah, that definitely makes, my symptoms, worse. She also had some symptoms of bowel and bladder urgency. She had issues with gait imbalance, leg weakness, and left shoulder and forearm pain, although those symptoms were now improved. And also really important to ask patients, what makes your symptoms better? What makes your symptoms worse? She did not really acknowledge any specific alleviating or exacerbating factors. So Addie, if you were to, I know you're very early in your training, but if you were sort of to maybe try to localize this, as we like to do in the neurosciences, where would you maybe guess that this patient's symptoms might be?
So with the fingers, with the hand numbness, it makes me think like upper to mid cervical, but then I don't know how exactly the bowel and bladder would play into it. I don't know if it's continuous or maybe it's like metastatic issues that are causing multiple spinal level problems.
Yeah.
And then you also have leg weakness. I don't know if it's like throughout the spinal cord or if it's just like localized edema that's causing these other issues.
Yeah, you're thinking about this exactly correctly. So what I tell patients is that, the spine controls everything below, okay? So if you have if you can imagine there's a spinal cord, nerve roots exiting out, right? If you have something pressing on just a nerve root, then you're just going to have, that nerve root issue. So, let's say you have a C5 to C6 disc herniation, just pressing on the C6 nerve. Well, that's just going to cause kind of maybe shooting pain, numbness, tingling, whatever in a C6 dermatome. which is generally kind of shooting into your, biceps and then into your thumb, right? If you have something pressing on your spinal cord, well, the spinal cord carries all the nerves. And so that can affect not only your arms, but also your legs. And specifically with, cervical myelopathy, that can affect your arms, your legs, and your bowel and bladder. Those are all the questions to ask when someone comes in with what you think is a possible cervical issue, as you've identified absolutely correctly, is, do you have trouble using your hands? You want to ask them, do you have trouble buttoning your shirt, opening jars, etc.? Do you have troubles with walking, right? Do you have any changes in your bowel or bladder habits? And if they do have severe spinal cord compression, then that's going to be, issues with urinary incontinence, bowel incontinence, etc. So to answer your question, yes, something in the neck absolutely can affect your legs, your bowel, your bladder. And I think as you get later in your M1 year, you're going to learn more about upper motor neuron versus lower motor neuron signs. And generally, spinal cord compression will cause upper motor neuron signs with weakness, atrophy, bowel bladder issues, hyperreflexia, etc.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.